Support for the Health Channel podcast comes from Florida Cancer Specialists. Florida Cancer Specialists urges everyone not to postpone recommended screenings such as mammograms, colonoscopies, or biopsies. Regular screenings save lives. More at flcancer.com/getscreened.
Welcome to the Health Channel, all health all the time. I'm Olga Villaverde, coming to you from the Baptist Health South Florida studios. So on our All About Cancer show, we're going to be talking about minimally invasive approaches to the thyroid gland. This is something that really a lot of people don't think about, but it does happen, and we're going to be talking about the newest techniques that'll help you get through this. And joining us today, we have two fabulous experts with us. We have Chief of Endocrine Surgery at Miami Cancer Institute, Dr. Robert Udelsman, and Dr. Nita Arengeri, endocrine surgeon, also at Miami Cancer Institute. Welcome to both of you.
Well, thank you, and good morning.
Both of you, I kind of want to first start with just Anatomy 101. Can we do that? The thyroid gland. Doctor, first tell me, what it is and the importance behind it, because it's really important.
So the thyroid gland is a gland located in your neck, and it controls many aspects of metabolism by making thyroid hormones, of which there are two. But the thyroid gland is a gland you take for granted until the day that you have a problem.
So true. So true.
Either you have too much thyroid hormone or too little thyroid hormone, and each can be problematic.
And if you have too much, that's hyperthyroidism, and if you have too little, it's hypo.
You got it exactly right.
Both are treated differently, and we're going to talk about that as well. How does it work, Dr. Arengeri, just in our body, regulating all those hormones that are so important?
So basically, you have signals throughout your body that that communicate together. So you have a signal from your brain that is released when you need extra thyroid hormone if it is responding appropriately, and when you have enough thyroid hormone, that hormone is downregulated then, because the thyroid hormone releases. The thyroid releases its hormone, which then circulates to the rest of the body and has an effect.
All right, fantastic. All right, we have different types of thyroid cancers. There's actually several of them, in case you didn't know. It's not just one. So let's take these one by one if we can. Papillary is the first one, I believe, Doctor?
Yeah, so papillary thyroid cancer is actually the most common type of thyroid cancer that we see. And it is most prevalent, it is diagnosed very commonly, and it also has a very good prognosis. So
okay, good.
From a patient standpoint, actually, it's the least aggressive of the thyroid cancer. So it tends to be a very slow growing cancer. It can occur on either side, as Dr. Udelsman was explaining, and does have that kind of typical spread pattern if it does spread outside of the thyroid gland.
All right, and then we have a few more. Are those less common?
They are, yeah. So
more serious?
They are in increasing kind of level of aggressiveness. So anaplastic, the last one, is extremely rare, but the most aggressive as far as thyroid cancers go. And then follicular and medullary, again, intermediate in regards to the aggressiveness level. And there are a spectrum for each type of these cancers, but they are less common as we go. The vast majority of patients with thyroid cancer are presenting with papillary thyroid cancer.
All right, Dr. Udelsman, do we know what causes thyroid cancer? Are there risk factors? Is it a genetic predisposition, your parents, or all of the above?
Well, it's all of the above, but let's try to break it down into a little bit more simplified manner. The vast majority of patients with thyroid cancer do not have a clear reason why they have it. It's spontaneous, it occurs in the general population, and we actually have an epidemic of thyroid cancer, not only in the United States, but throughout the world. And the reason, at least 50%, is because we have incredibly sensitive imaging in the form of ultrasound, and we're seeing tiny, tiny little thyroid cancers for the first time. And believe it or not, we believe that some of these thyroid cancers can be watched and don't necessarily need surgery, and certainly not aggressive surgery.
All right.
But there are other patients who do have family histories, and there are rare genetic syndromes associated with some very interesting and complicated forms of thyroid cancer, particularly medullary cancer of the thyroid. And finally, radiation exposure, particularly children who are radiated in by accidents such as Chernobyl or other areas, are at higher risk throughout their lifetime, and they have a latency period or delay from the time of exposure to the time of cancer can be 30 years. So those patients need to be followed for life. They're very interesting and complicated.
There's been numerous new approaches, and they've been over the years to improve the cosmetic outcomes of thyroid surgery. So there's one I want to talk about, Dr. Yudelsman, it's transoral thyroidectomy. We have great pictures to show our viewers. I want to say there's about 5 or 6. So first tell us what transoral thyroidectomy is, what kind of technique this is.
So a little bit of background, Olga. So this really excitement began in the Asian countries where women in China, Japan, Thailand, South Korea are very concerned about the appearance of their necks. The neck is a very important area for Asian women. But it began in Asia because women didn't want a neck incision. And therefore, surgeons developed techniques which are sometimes seem almost barbaric. For instance, going through the axilla, the armpit, going through the breast. That's a technique that we use. And in our case, we found all of those techniques to be pretty complicated and difficult. A surgeon in Thailand worked on a technique to go through the lip. The entire procedure was done through the lip, going down over the chin
to get to the
neck,
thyroid.
To get to the thyroid. 3 months later, you can't even find the suture line. It's impossible because the lip heals differently than the skin on the neck.
But that's a lot better in terms of, and Doctor, let me bring you in now, in terms of, you know, a woman or anybody who doesn't want to have that ugly scar there. That's really a great approach.
I mean, and that's exactly really why it is an option for patients. It is for the cosmetic closure effect. The neck does heal very well from an open incision, but if you do not want a visible incision, this is what we find to be kind of the best approach for that.
And I only got about 10 seconds left, but what's like recovery? Pretty fast?
Pretty fast. 1 night in the hospital, they generally go home the next day, eating regular food. Really big on oral hygiene right after because we want to make sure those stitches stay clean, and usually, you know, kind of back to normal in a week or so.
Love to hear that, back to normal. Fantastic. If you haven't already, download the free Health Channel app. It's available at the App Store or Google Play. Doctors, would like to take a phone call if you don't mind before we continue our we have Dawn from Palm Beach Gardens, I believe it is. Hi, Dawn.
Hey, good morning.
Good morning. How are you?
I'm good, thank you.
What's your question, dear?
Okay, so I have thyroid nodules, and I'm 57 years old, and they were found just basically accidentally when they were doing some checks of the arteries in my neck. And so I went and had them diagnosed, and they were found to be benign. And I was wondering, I understand a lot of it, mostly women seem to get this, and I thought it odd that I would get it after researching it because it was found accidentally. I had no idea how long I had them. So I was wondering, is there anything I can do to keep them from growing or converting into cancer, such as what I'm eating or my stress levels or anything like that?
Great question. Great question. Dr. Yudelsman?
Well, you brought up many important issues. Number one, you mentioned that you thought it was unusual that you were male. Thyroid cancer and thyroid nodules are 3 times more common in women than men, but it does occur in men as well, as your case shows. The fact that you had a biopsy and they're benign is very reassuring. A biopsy of a thyroid nodule is a very good diagnostic study, but nothing is 100%, so therefore you need to be followed for life by a competent doctor, and it sounds like you have one. Also, you asked about what can cause them to grow. Well, the first and most important thing is to make sure your thyroid hormone levels are normal, and I'm sure your doctor checked them, and I'm assuming that your TSH and thyroid hormone levels are normal. And finally, you asked about converting from benign to malignant. That essentially never occurs with rare exceptions. So benign nodules start out as benign and they can grow and get bigger, but big cancers start out as little cancers and they get bigger. But generally speaking, with rare exceptions, they don't convert from benign to malignant. So in your case, you can be followed very comfortably without surgical intervention for perhaps your whole life and never have them removed.
Wow, that's good to hear. And unfortunately, my brother passed away from throat cancer. So and he was just a few years older than me. And when I found out that I had these thyroid nodules, well, you can guess where my thoughts were. I was scared to death and pretty much still am. He looked like he was in perfect health. And then when I asked him, how did he get this? He didn't smoke, he didn't drink. He said it was all based on stress. And I have a pretty good-sized stress level with my career and family and everything in basic life. So I quit drinking alcohol entirely. I've monitored my sugar levels, and I'm getting ready to go in for my annual sonogram to see if they've grown or not. So that's where I am, and it was very reassuring to hear that you said they do not normally convert into cancer. So that's been my biggest fear.
Sure. And just a comment about the stress. So there's a concept about immune surveillance and stress, that stressed individuals are a little bit compromised in their immune systems, and that makes them at slightly increased risk for cancers. But the fact of the matter is that we're all stressed. There isn't a human being alive who isn't stressed, and the data are very soft on proving a direct relationship between the two. So obviously, there are many reasons to relieve stress in your life, but stress is part of living, and they're very difficult to avoid, like doing this interview right now, for example. So we all live with stress. It's how you deal with that stress in your lifetime.
Absolutely. Oh, Don, thank you so much for calling into the Health Channel. First and foremost, I'm so sorry for your loss with your brother. And I must say, I'm so glad you called in. It sounds like this is one individual who is done, sounds like he's doing everything right, and he got educated, he quit drinking, good for you, eating better. So he's doing everything humanly possible, which is fantastic as well. Thank you, Don, again. All right, Dr. Erinjeri, I want to now cover, if you don't mind, hyperparathyroidism. What exactly is hyperparathyroidism?
So, as we kind of alluded to earlier, the parathyroid glands are 4 small glands that reside next to the thyroid gland and a little bit behind. There's the expected locations, which are right tucked up kind of underneath and behind the thyroid gland, but there are a lot of other locations where they can be based on how they migrate during embryologic development. And primary hyperparathyroidism, which is the main reason that as a surgeon we get involved in parathyroid disease, is where the parathyroid glands, whose job is to control calcium levels in your bloodstream, stop responding to the natural signals, and they overproduce parathyroid hormone, which leads to increasing levels of calcium in the bloodstream.
Okay, and those calcium levels in the bloodstream obviously not good to have.
Yeah, the high calcium in the bloodstream is not good because that in and of itself causes some issues, but also from having high parathyroid hormone, that also causes other problems in that it affects the bones, it pulls calcium out of the bones and can cause bone thinning, osteopenia and osteoporosis, and then the effects of the actual calcium itself can cause many symptoms, general symptoms, fatigue, memory fogginess, difficulty with concentration and thinking, as well as abdominal pain, loss of appetite, constipation. There's a vast majority or vast breadth of symptoms that people can present with.
All right.
So first of all, I want to emphasize, Olga, that the vast majority of patients with parathyroid tumors, primary, secondary, or tertiary hyperparathyroidism, do not have parathyroid cancer.
Got it.
Parathyroid cancer is rare, and at the Miami Cancer Institute, we deal with both benign and malignant nodules and tumors. So the vast majority, we're not really worried about cancer, but it produces this hormone that Dr. Erinjeri so nicely described. The hormone is released from the parathyroid glands, goes into the bloodstream where it binds to receptors in areas like the bone, and the abnormally elevated parathyroid hormone levels force the bone to release calcium inappropriately into the blood system. That's why calcium's high in the blood. The high calcium goes to the kidney where it gets excreted, and that can form things like kidney stones, or it can actually calcify the kidneys. So it's a vicious cycle. As long as the parathyroid hormone level is high, the bones pay the price, the bones get weak, the patients get osteopenia and osteoporosis, or risk for bone fractures. So that's part of the reason we like to fix these problems early.
All right. This invasive transcervical parathyroidectomy. Now, this is another technique. How does it work? Paint the picture for us.
So we recognize that 85% of patients with primary hyperparathyroidism only have one abnormal gland. And if we know where that gland is, as we can image by a variety of imaging techniques preoperatively, we can design an operation custom-made for the patient, and we can do the operation under a cervical block technique. We don't need general anesthesia. We can make a tiny little incision, go in there through the neck, take it out, and then during surgery, use a hormone analysis to prove that the parathyroid hormones fall appropriately, and we can even send them home the same day.
Really?
And we do that all the time. So the majority of our parathyroid surgery is done as an outpatient using the techniques we just described, and that's what a minimally invasive parathyroidectomy is.
All right, is this for anyone? Can anyone, everybody's a candidate?
Everyone's a candidate, but everyone
However-
might be appropriate. So again, it's the same process. We see the patients, we screen them, we do their imaging, we confirm the diagnosis, and then we have a conversation.
What's the recovery like, Dr. Eridu?
So for patients who go home the same day, it's exactly that. They're usually back to kind of their normal levels of activity that night. You're eating regular food. People think they can't talk. They can. You're able to do realistically whatever you want. Pain for a couple of days, and realistically, that's about it. We see them in the office about 3 to 4 days after surgery, and you know, we have a look at the incision. Usually things are healed up very well, and we release them back to full activity and whatever they want to
Are
do.
they surprised to hear just how, you know, you're in and out in the procedure? I mean, what are they saying?
We actually prefer not to say that. We tell them, we hope it goes perfectly well. So we like to do as little as necessary, but as much as required, because we never know what case it seems is going to be very straightforward turn to a much more complicated operation. What we don't want to do is fail to cure the patient at the first operation. That's our gold standard. So at the end of the day, we have 3 concerns: cure, safety, cosmesis, in that order, not the other way around. Cure, safety, cosmesis.
I agree with you. And you are cautiously optimistic.
Of course.
That's what I'm going to say from now on. We're going to talk about another procedure. It's minimally invasive transoral parathyroidectomy. Another mouthful. We're going to get to that, what it is, and the story of a woman, actually, a wonderful lady. She's going to join us. Her name is Lynette Boudou, who had this procedure. I believe it was the first here at Baptist Hospital.
The first in Florida.
First in Florida. Fantastic. If you haven't already, download the free Health Channel app. It's available at the App Store or Google Play.
I'm glad to be here.
You're nervous. I know you are. But we had so much fun talking before the show started. So, are you having fun yet?
Not yet.
Not yet. Okay, but we are going to. All right. So we talked about primary hyperparathyroidism. That's what you were diagnosed with.
Correct.
All right, doctor. Quickly tell me again what that is before I ask Lynette a question or two.
Primary hyperparathyroidism is an abnormality where one or more parathyroid glands secrete parathyroid hormone levels inappropriately in the body, resulting in hypercalcemia in most cases.
So a worst case scenario for that person would be?
Those patients can develop severe neurocognitive dysfunction, depression, anxiety, insomnia. They can also develop severe bone loss, osteopenia, and
Oh, wow.
osteoporosis.
A whole host
and
of
they
things.
develop kidney stones on top of that.
All right, so Lynette, tell me your story in terms of before you're diagnosed, what was going on? What led you to Dr. Udelsman?
Well, I had been running a high parathyroid for a number of years. My primary had sent me to an endocrinologist because my calcium levels were high,
Were very
as
high.
doctor spoke about.
Okay.
And so in 2017, my endocrinologist found that I had a small nodule on one of my parathyroids. And in January of this year, he suggested that I have a consult with Dr. Udelsman.
And he suggested because of that nodule?
And because I was running this high parathyroid for a number of years.
Okay. When she comes to you, doctor, then you notice what?
Well, the first thing is we verify the diagnosis because sometimes patients are sent inappropriately. She was completely appropriate. She had clear indications for surgery. And then the question becomes is where is this abnormal gland? In her case, she had a good suggestion, but then we had a very interesting and unusual conversation because I described doing an incision, a standard incision at the base of her neck, and she told me she wanted something different.
And she wanted something different, because that would be the protocol, right? An incision here in the neck?
That is the
for
most common approach.
And that would be that's called what, doctor?
A transcervical, minimally invasive approach,
Which we just
I
covered.
was happy to offer her and did offer her. And she said, well, I want to have a conversation about that.
And she wanted to have a conversation about that because you have a skin condition that was concerning you. What is that, Lynette?
It's vitiligo.
Vitiligo?
Yes, where I have been losing my pigment.
So you have this condition on your arm and your body?
Yes.
Okay, and that condition is what? Could you define it for me?
Well, it's just that I'm losing my pigment because the melanocytes are no longer there.
Okay, now when you notice she has vitiligo, that's what it's called, vitiligo, then you realize, okay, we can't do this because...
I didn't quite realize it. She educated me.
She has to tell you, okay.
Because this is a fairly rare skin condition, and I'm not an expert, but it turns out that about 20% of patients with vitiligo, when you make an incision, it activates that immune process where they destroy the melanocytes, the pigment cells, and that area becomes white or depigmented. And she told me the story that her beautician nicked the back of her neck, and sure enough, on the back of the neck is a little white spot.
Yeah, and the thing is, it would spread.
Obviously. Understandably so, right, doctor?
So yeah, so we now have this condition where I know if I make an incision, I'm probably going to activate this response so that she gets this white depigmentation, which she liked to avoid. And she then said...
Well, I said to him, am I a good candidate for the transoral parathyroidectomy?
Oh my gosh, you go, girl. I mean, you're completely educated on this, and you even knew the whole term. This is the first time I hear about this, transoral parathyroidectomy. So you had already done your homework?
Well, I'd read a lot about doctor and
Good
what he
for
had
you.
done.
Okay, so
I
she
know
wants...
he had done this on the thyroid.
All right, so she wants to have this technique, this procedure, I should say, and she does. And this is the first one in Florida, here at Baptist Hospital.
Yes, it's all true.
Fantastic. Were you nervous a little bit to be the first?
Well, I didn't know I was going to be the first.
She's
So I was
cute.
not nervous.
So when they told you you're the first,
Yeah, doctor told me after the surgery.
what were your oh, after?
Well, let me say this.
you
She's the first in Florida, but not the first for me, and not the first in the United States.
Okay, that's a great clarification. All right, so it's always great to be the first. You see, your name is in lights already and stars. Okay, so tell me exactly what the transoral parathyroidectomy is and what you did.
So as we showed in the transoral thyroidectomy, it's essentially the same operation. We went through her lower lip, over her chin with our trocars, down into her neck, and we knew where the parathyroid gland was, and I have to tell you, it was pretty easy in her case, because parathyroid tumors, which are benign, are much smaller than the average thyroid tumor, so it made everything a lot easier. And it didn't take us very long, and she had a really nice operative result.
So you have your incision in the, forgive my ignorance, the upper or lower lip?
The lower lip.
The lower lip. You know,
It's
nothing.
totally, you can't find her incision.
I love that. Tell me about your recovery. How was it?
Well, it was, I just spent one night in the hospital. That morning I had breakfast, and then I went home around lunchtime.
All right.
And I had no pain for the entire surgery. I felt no pain
Oh, that's fantastic.
after.
So is she cured now, doctor?
She's
I
cured.
always try to be careful when I say that word.
Yeah, she's cured biochemically. That's how we monitor this disease. Of course, we follow these patients for life, really not myself, but the endocrinologist. But because she had a single gland abnormality and she had a good biochemical response, her recurrence rate is really in the 1 or 2% range in her lifetime. So it's excellent. So we expect her to be fine. And of course, over time, her bones will improve. We think her thinking will improve, but it's hard to measure that sometimes. So, but people do report to us that depression,
She's funny.
anxiety gets way better after surgery.
Oh, do you feel something? Do you feel better physically, emotionally, spiritually after the surgery?
Well, yes, I do feel better
Oh, that's good.
in all
what
those
way?
areas.
Yeah?
And
Can you describe it to me? In what way?
well,
Be more specific, maybe?
I am less tired. I used to be quite tired.
Okay.
And then the thing is, my calcium levels have gone down to normal levels, which is very important because I do have osteopenia.
Okay. I know I wanted to cover a couple things. You did tell me before you came on the show that your sister also has this condition, or had, I should say,
yes.
past tense. Okay, doctor, is this genetic?
Yeah, that is a concern of ours, and it concerned me about you, because when we have familial cases, it's usually multi-gland disease and not single-gland disease, and the transoral approach is not a good approach for multi-gland disease. But in her case, because of her concern about that, we really imaged her with a very high quality, what's called a 4-dimensional CT scan, which was exquisite in detail and suggested just a single gland. So I said, okay, because of your compelling reason with the vitiligo, I think you're a good candidate. I just want to mention something. At the end of the day, no matter how much a patient wants something, if we don't think it's appropriate, we won't do it.
Absolutely.
We'll just say, I'm sorry, I can't offer this to you. Maybe I can tell you someone else who might, but I won't do that if it's not appropriate.
And that's the right thing to do, and that's the Hippocratic Oath right there. Lynette, I'm going to quote something that you told my producer, Isabel. You said that you are very grateful, quote, for Dr. Yudelsman because he really cares about his patients, and you felt he cared about you. Mm-hmm. Oh, my gosh. Could you describe just that feeling of what he gave you?
Well, the reason I have come to that conclusion is, you know, the first time that I visited him, he was going to give me a cut on my neck. And at the second visit, when I explained to him about my concerns about my vitiligo, he said, well, let me research this. So I saw that he wasn't dismissive. He listened to me, and afterwards he said, you know, we have indeed found out that this happens. So that was just a bonding that that showed me he cared.
He went the extra mile, didn't he?
Yes, because he didn't have to do it.
I know.
And also he had to do different little things with administration before I had the surgery, which he could have just said no.
He said, no, I can't. How grateful are you, Lynette?
Very, very grateful. And thank you, doctor.
You're very welcome. You're very welcome.
How does that make you feel?
Oh, it's what we do. This is why we live. This is what we do every day for patients. And let's take it beyond you. So patients who don't heal properly, like patients who form keloids, and some of them are dramatic, this approach makes a lot of sense. And the reason I think you're so important as a patient is you're the first patient in the world with a combination of vitiligo and primary hyperparathyroidism treated this way, but I think we can extrapolate this technique to many other individuals. That's why this is so important. It goes way beyond you. And by the way, I had to prompt her a little bit to come on this television show today, but her response to me is always the same. If it helps others, I want to do it.
If you haven't already, download the free Health Channel app. It's available at the App Store or Google Play. So in this last segment, we're going to discuss minimally invasive approaches to the adrenal gland. So just like we did before, I always like to do Anatomy 101. So Dr. Erin Jerry.
Actually, the adrenal glands are two small glands that you have on either side. They sit on top of your kidney. So this is, you know, very far in your back and much lower down than what we've been talking about in the neck. And the adrenal gland has a capsule around it, and then it has this outer layer, which is broken up into 3 zones, and each zone produces a different type of hormone, and then the central layer called the medulla. So you have the cortex and the medulla, and they produce different hormones that are then secreted throughout the body. And that's its major function, producing those hormones and how those hormones affect the rest of the body.
All right, so it's located near the kidneys, and what are the hormones for? They produce the hormones to regulate...
So each different area produces different hormones. So in the cortex, you have 3 major zones, and those zones produce mineralocorticoids, glucocorticoids, and androgens, or the sex hormones. And so the mineralocorticoids affect your blood pressure in regards to how your body secretes and absorbs water and salt. And the glucocorticoids are steroid hormones that are help regulate the stress response, and then the androgens affect sexual development and drive. And then in the medulla, which is the center portion, you produce your catecholamines. This is your fight or flight response, norepinephrine, epinephrine, what people think of as adrenaline coming from the adrenal glands.
All right, okay, so lots of functions there, lots of hormones. So 2 common ways that it can be affected in terms of our health would be too little or too much being produced. Can you explain that to our audience? I guess that would be the same concept that Dr. Yudelsman and I were talking about, hyper, too much, too little.
Yes, and it's a little different in the adrenal gland in that it's based on each specific hormone. So you can have tumors within the adrenal gland that overproduce certain hormones. You can have overactivity because of stimulation from the brain. Like all endocrine organs, it's a feedback mechanism. And so the adrenal gland receives signals and responds appropriately or sometimes inappropriately, which is when we run into the situation of too little hormone production or too much hormone production. And those presentations vary based on what hormone is in imbalance.
Thank you for that great Anatomy 101. She mentioned adrenal tumors. So tell us, I guess, how does it occur? And if so, I guess the dangers and the health issues behind it.
First, let's define tumor. Tumor means an abnormal growth. They're usually benign, but they can be malignant. So we deal with all different kinds of adrenal tumors. They're either functional or non-functional. If they're functional, they produce too many of the hormones that Dr. Aaron-Jerry so nicely described. If they're non-functional, they just grow, and we can watch them. Of course, any tumor present, whether it's functional or not, has the potential for being malignant or cancer, and we have to deal with those consequences of what to do about them.
There are definitely reasons that people have to have surgery on the kidneys. But what we are talking about specifically is in an adrenal tumor, especially if we're talking about a benign adrenal tumor, we tend to remove the adrenal gland and leave the kidney in the body.
Okay.
And we remove the adrenal gland. And generally speaking, the surgery is to remove the entire adrenal gland, not just carving out the tumor, but there are rare instances when someone has had one adrenal gland removed and we're having a problem with the only remaining adrenal gland, where we could do what's called a cortical sparing adrenalectomy, which would be a partial adrenalectomy to leave some tissue behind.
Could you paint the picture, as I always say, of what would be done to remove that tumor?
So in that instance, we would actually remove the entire adrenal gland with a surrounding soft tissue or fatty tissue layer to ensure that we have removed all of the tumor. What we don't want to do is leave behind cells of tumor, and these tend to be very soft glands, and so the best way to do that, if they have a remaining normal adrenal gland, is to remove the entire thing.
And Dr. Udelsman, is this minimally invasive surgery as well?
Yes, so there are different approaches to the adrenal gland, depending, for instance, if a patient has a very large aggressive cancer, they need a very large aggressive operation, and this would not be appropriate. But Dr. Aaron-Jerry is a world's expert on the smaller tumors and minimally invasive approaches, particularly a posterior approach, and I believe you're the only person in Miami, certainly, and maybe in Florida, doing this posterior approach?
I'm not certain.
You're being humble.
At Baptist, though, this is one of the things that when I came to Baptist that I really have been moving to have the program here, because as discussed, there are many different ways for any surgery that we can approach things, and it's based on a multitude of things. It is based on the patient, their history, their body habitus. It's also based on the tumor, what type of tumor it is, where it's located, how aggressive it looks. As Dr. Udelsman mentioned, if you have a very large invasive tumor, then the surgery has to be appropriate for that. We worry about cure first. But for the vast majority of adrenal tumors are small, and we can approach them from a minimally invasive aspect.
Unfortunately, we're nearing the end of the show, and I could go on for hours here. I did want to just mention that even being with you both, which has been such a delight and a pleasure, I see just such a great relationship, and I wanted to chime in on that in 30 seconds, and I can only imagine your patients appreciate it. I could see like a dynamic duo here. It's important, isn't it, doctor?
Well, I think it's incredibly important. First of all, surgery is a team sport. We work together, and it's not just doctors, it's the nurses, it's the technicians in the operating room, it's everybody we work with is critical. But also, frankly, I'm so lucky to have Dr. Aaron-Jerry working with me. Our patients do better. We scrub together in almost every operation, so it's really a great pleasure for me to have her working with me.
Truly appreciate your time.
Thank you
so much for coming in. Hope to see you again soon. And that's all the time we have for today as well. I want to thank both experts, and I also want to thank Lynette for coming. Follow us on Instagram, Facebook, and Twitter at All Health TV, where you can get health tips from our experts and see what's coming up on the Health Channel as well. Visit our website, allhealthtv.com, and if you haven't already, get the Health Channel app. It's absolutely free. It's fantastic. Thousands of videos there. You really will enjoy it. I'm Olga Villaverde. We'll see you next time. You take care.